Good afternoon, everyone. Welcome to our coffee break, and thank you for your interest in the effect of COVID-19 on early pregnancy. My name is Laurentiu, and I will be your moderator today. I am pleased to introduce our expert, who is Dr. Meena Choudhary, a consultant gynecologist and subspecialist in reproductive medicine at the Newcastle Fertility Centre at Life in Great Britain. Her key research interests cover early pregnancy loss, reproductive aging, ethics, and gamete donation. She is the HFEA person responsible for research at Newcastle Fertility Centre. She also leads the recurrent early pregnancy loss service at Newcastle Hospital, and she is the lead for egg and mitochondrial donor program for the world first licensed treatment for mitochondrial replacement techniques. Before we start, there are a few housekeeping rules that I would like to mention. There are two ways to interact with Dr. Choudhary. One is to raise your hand, and then you will be able to speak directly. Or if the connection is not very good, you could post your question in the Q&A chat box at the bottom of your Zoom screen. In terms of the content of the discussion, I would like you to be honest and truthful and try to be appropriate when engaging. Our topic is not controversial, so I don't expect any heated discussions. The views you are expressing are your own, so you are responsible for your own words. A few things that you shouldn't mention are rumors or fake news or information that you suspect might be false. And please try not to use this platform for commercial purposes. Thank you, Dr. Choudhary, for agreeing to join us in this afternoon. The floor is yours.
Thank you. Laurentiu, is it for my turn to say something? Or?
Yes, please.
Sorry, I wasn't very clear. Good afternoon, everyone. It is a pleasure to join you all for a coffee break for ESHRE's first virtual Congress meeting. And it's a special year for me as well because I was nominated to share my story as one of the humans of ESHRE. So I'm very pleased to be part of this, and I hope you enjoy our coffee break session today. Now, as you know, we were just going to discuss about what is the effect of COVID-19 on early pregnancy. But at the same time, it has got three elements, I would say. One, how COVID-19 affects early pregnancy and its delivery of care. Second is effect of pregnancy on COVID-19. And lastly, how do we manage these conditions? So talking about it, I would like to first emphasize there are not much research or studies and case reports out there, but there is emerging evidence of quite a few cases in early pregnancy, but it's very, very limited. One of the most important one, which was published just in June 2020 in BMJ, British Medical Journal, is the UK Obstetric Surveillance System study report. Now, in UK, there is a very well-established system, as you may know, that there is all NHS hospitals which provides obstetric care, and 194 units took part in this. And what they did was they reported every case of COVID-19 of patients who were admitted in the hospital based on the hospitalized patients. Trying to extrapolate early pregnancy data, because this talk and session is only about early pregnancy, what the study showed that out of 427 women who were hospitalized with COVID-19 in pregnancy, 22 of them were less than 22 weeks of gestation at onset of pregnancy, of which four experienced pregnancy loss at between 10 to 19 weeks of gestation, two of which were early pregnancy losses, so which is less than 1% overall that experience early pregnancy loss. So there is no evidence to show that COVID-19 affects early pregnancy loss or causes early pregnancy loss. But the four important features they found as high risk factors for COVID-19 admissions in the hospital during pregnancy And they were quite high. So like maternal age of 35 years was known to be a risk factor in 40% of women. 7 out of 10 were found to be obese with a high BMI or overweight. One third, around 30 to 33%, had pre-existing comorbidities like diabetes or hypertension. And a huge proportion, more than 50%, half of them were belonging to ethnic minority. This has come out a very starking feature in not only in this study, but also overall with COVID mortality and all in USA, in UK, everywhere where it was shown that BAME group is more susceptible to it. It may be because of other factors, economic, socioeconomic factors, but this was highlighted, which needs to be explored further. So this is the background we have of limited data. There are a few other case reports published, but nothing which adds on significantly about effect of COVID on early pregnancy. So how do you manage women with early pregnancy, especially if they've got problems during COVID-19? I would like to refer you to this Royal College of Obstetricians and Gynecologists from UK, which is a national professional body, their guidance for rationalizing provision of early pregnancy care during this pandemic. So they came out with this traffic light system, which is quite easy to understand and decipher. If you follow similar one, great. If not, you may get some tips which you can take away from you. So one of it is the red, which is the most risk factor. So if someone presents with early pregnancy problem and has, you suspect possibility of ectopic pregnancy, you have got significant pain or heavy bleeding, and they're symptomatic, then it is worthwhile offering ultrasound scan and to be seen within 4 hours possibly, but offering ultrasound scan within 24 hours. The next group, which should be the amber group, would be if they don't have those severe symptoms, but they've got some moderate bleeding or they had heavy bleeding which has settled. In that case, you don't need to see them in the hospital. You can offer a telephone triage or telephone advice and arrange for them to have a home pregnancy test in a week's time, or assess it whether if it's still positive, whether we need to see them for a scan or assessment or repeat the test in a week's time. And lastly, the green one, which is that if they're asymptomatic or just have some light bleeding or mild cramps, or it was just a reassurance scan, for example, in recurrent pregnancy losses, we offer early pregnancy scan for reassurance, then they don't need reassurance scan. We don't offer any scans during this COVID period, and they can just book for routine booking scan at 12 weeks in the routine antenatal care, but they definitely have telephonic support if they have symptoms or if they've got any concerns. This was the hardest group because the psychological impact of not able to offer early pregnancy scan can be quite distressing for women going through recurrent pregnancy loss. So you have to bridge that quite carefully and with good counseling support. How do we manage COVID-19? So if someone comes up with symptoms of COVID-19 in early pregnancy, how do we manage that? I would say that if they've got mild symptoms, they're clinically well, then they can stay at home. They don't need to come in the hospital. They need to self-isolate so they can protect others. And it will be good to book a test for them and also inform their healthcare professional or midwife going forward so that they can provide them with the right advice. Admissions are only recommended if conditions deteriorate. I have put it as a 3S protocol or 3S approach. One is the standardized care, which means whatever the standard protocol, as I discussed about self-isolation, staying at home, personal hygiene, and the COVID-19 pathway for outpatient management, including multidisciplinary input with infection control, everything would fit into the standardized care pathway for COVID-19. Stabilizing is the next S, which is if the patient is symptomatic and they're coming to a hospital for moderate or severe condition, then you need to stabilize them first. The aim is to give them nasal oxygen, supplemental, with keeping the oxygen sats at 94% or lower than that, higher than that actually. And also to be vigilant for signs of decompensation and fluid management. It's very important that we ensure that they do get this care, and oxygen in COVID cases has been therapeutic rather than just supplemental add-on project. Lastly, the specialist input that is required, or the specialized care, which may involve low threshold because they are pregnant, so low threshold for antibiotics that are safe in pregnancy. Pregnancy itself is at high risk of thrombogenic condition. So VT assessment and introducing thromboprophylaxis sooner, avoiding fluid overload because we don't want to do that because that can contribute to more problems, and consider steroid therapy. There was a UK trial led by Oxford Group, recovery trial, which looked at steroid use, not in pregnancy, but overall, and did show benefit with dexamethasone given over 10-day period. But one needs to know that this benefit is mainly in the inflammatory phase before the cytokine storm hits. So if people don't know, COVID-19 has got 3 phases. The initial one is the viremia phase. The next one is the inflammatory phase, which could be early inflammatory or late inflammatory. And lastly is the cytokine phase. The cytokine storm is the risk where they may need ventilation, or which is the most risky factor. So you have to consider this, but you will need multidisciplinary input for this management. So this is how we would go about briefly discussing about it, but I will pass the stage back on to Laurentiu for active discussion with you all who have joined us. Thank you.
Thank you, Dr. Choudhary, for your presentation. Now is the time to start the discussions with the floor. If anyone has questions, one way would be to raise your hands using Zoom, or you could write your questions in the Q&A box. I will start with the questions until somebody else comes with a different one. Dr. Choudhary, we agree that data is very limited in relation to early pregnancy and COVID. How do you see things going forward? What would be a good way to progress with the research? What kind of angles would you tackle?
Right. Okay. So, so what I gather is that your question is in relation to if we don't have, I mean, currently the research is limited. So what can we do to focus our research priorities? So I would say that the most important thing for this would be to focus on, for this session, especially to focus on early pregnancy thing. And one of the things would be diagnostic. So is there something that we can come up with diagnostic pathway? Currently we have been used depending more on techniques or methodology of testing it, but we may need to know what diagnostic tools. One of the things would be to look at vertical transmission in those diagnostic things. So for instance, can we do analysis of if someone has early pregnancy loss, or if they go through a termination with COVID symptoms or COVID positive patients, to assess those tissue products of conception to see, is it associated with SARS-CoV-2 host receptors presence? Is there a vertical transmission that will give us more information? We can do genomic studies on that as well. Also, infection during early pregnancy, what is the long-term outcome? We don't know that yet, because the first cases were picked up in December 2019 in Wuhan, as we know. So those early pregnancy or peri-implantation phase who conceived during that time and had the infection, the long-term outcome to the mother, to the baby, were there any birth defects? So far, whatever limited data, it doesn't show any adverse outcome, but that is a very interesting and very key research priority, I would say. There was a very good talk early this morning in the COVID-19 session by one of the Belgian young scientists who talked about presence of these receptors in eggs and embryos, ACE2 receptors and all. And that was a fascinating research, I think. And I think one can take that further to see if affected women have these things on their eggs and all, what would be the implantation and early pregnancy outcome if they develop, because not all of the eggs would be tested. But knowing that they are present, can we test some of those eggs and embryos before transferring and things like that? So research around that, as well as if they have been vitrified because they developed symptoms, they were not transferred and they were frozen, for instance, then subsequent pregnancy outcome in those and whether freezing causes. So there are lots of elements that can be done. But one most important thing I would like to say is psychological impact research is very crucial. And I think that would be a very good research priority for early pregnancy and its effect related to COVID.
Thank you. We have a question from the floor from Paolo Bianchi. Paolo is asking if you are aware of any case reports or any studies reporting on fetal malformations related to COVID-19.
Unfortunately, no. In the sense that I have looked at the literature, and there are studies that in early pregnancy, especially, there was one JAMA paper published as well, which talked about 19-week loss. And in the placental tissue of that 19-week, SARS-CoV-2 was found. But one can't say whether that was causative or just an association. We found that. But as regards fetal abnormalities and all, there are no studies which have reported that. So as of now, it says that there is no effect. I do know that if, I mean, everyone would probably know about, say, for instance, Zika virus. Initially, there was no evidence for it, but then subsequent evidence came out about microcephaly and other congenital birth defects, micrognathia and brain deformities that were found in those. And that's why there is a national and WHO recommendation as well, international recommendation globally to avoid conceiving, say, for up to 2 months for women and 3 months for men. If the subsequent research and observational studies case reports finds anything in future, then there might be recommendation coming in future to avoid a pregnancy with that. But at present, no, there is not that I'm aware of. Thank you.
Thank you. So another question from the floor by somebody who hasn't mentioned the name, asking about the choice of steroids. Is betamethasone as good as dexamethasone? And how should it be given and for how long should the treatment be? How would you also manage the patients who have underlying diabetes and are being treated with insulin? Quite a few questions in one. So I'll repeat them one by one. First one is the choice of steroids, betamethasone versus dexamethasone.
Right, okay. So the recovery trial, I mean, I would just, voice is not very clear, and I don't know whether there is some problem with my internet connection or network connection or what, but I'll try to explain. Recovery trial was looking at dexamethasone 6 milligram IV daily for 10 days, as I mentioned. So the studies were done with dexamethasone. There are management guidelines for steroids where they talk about prednisolone, methylprednisolone to be given. But betamethasone studies are they're not no randomized trial I'm aware of. However, I need to tell that I am not a virologist, I'm not an intensivist, so I may not be the best person to tell you definitely all about the studies. However, there is a good resource I would like to point out if you wanted, from epidemiology to diagnostics to steroids and all the therapies, including obstetric care. Brigham hospitals, Brigham Health in America, they have come up with an Apple iOS app, as well as a website which lists all the clinical guidelines and pathways with all current updates on the evidence in one place, which is very helpful and very good. So I would direct you to that source as well, apart from various other sources.
Thank you. Again, the second question is similar to the first one. How long should the treatment be? Probably further research will answer these questions in the future.
As I said, 10 days is recommended where they went, the recovery and it affected, the time to recovery was quicker with 10 days. So that's recommended when you're giving steroid therapy, but further research is required to give definite answer in early pregnancy.
Thank you. Another question from Priya Ashok, asking about the imaging modality to be used for lung assessment in pregnant women who have COVID symptoms. Is CT chest being carried out where indicated or a different imaging modality?
Right. So I'm assuming this question relates to imaging modality for early pregnancy rather than pneumonia or chest symptoms for chest. So for that imaging modality, it would still remain ultrasound, but the Royal College of Obs and Gynae, they have got, as I said, a rationalizing pathway guidance, and that recommends cases where you should do scanning, and that is, and also management of early pregnancy problems. So that is based on COVID status as well as urgency. If you're offering ultrasound scan for a high-risk patient for COVID or who has got a COVID infection, then you should provide that care in a COVID-specific environment, which is restricted for COVID area, with a COVID-specific ultrasound machine equipment and with proper PPE. So that is recommended. Not everyone would need it, but ultrasound would still remain the main modality from early pregnancy point of view to offer that. Management options has changed, so how we deliver the care at that point, apart from when we don't offer scans, as I was discussing earlier, is that if we say, for instance, find on ultrasound that this lady had unfortunately suffered a miscarriage or losing a pregnancy, then recommendation would be either to go down, say if it's incomplete, to go down expectant management rather than intervention, so she doesn't need to be in the hospital for longer, right, minimizing the footfall in the unit. If it's a miscarriage, then opt for home treatment package of medical management, which we have introduced as well in our center, and a lot of other units have done that. Or if it's surgical, then go for without general anesthetic, like MVA, which is manual vacuum aspiration, which can be done under local anesthetic rather than requiring any general anesthetic. So that would be the management. If it is ectopic, then again, you can diagnose it by ultrasound, but you can manage it specifically based on whether you want to go for methotrexate based on our hemodynamic stability and take all necessary precautions.
Thank you. And probably one last question, just like a case example. Say if a pregnant lady who's around 7 weeks pregnant has symptoms of mild vaginal bleeding and some left iliac fossa pain that's not too severe, and she has concerns about the pregnancy and concerns about contacting coronavirus if she was to go to the hospital, what would be your advice for her?
Right. Nice to have a clinical question, fully clinical. In similar situation, first of all, and first and foremost, we should remember that any pregnancy, regardless of whether there is COVID pandemic or COVID risk, needs to be early pregnancy problem should be managed clinically as we would do any clinical decision making or assessment. Secondly, it is very important that we initially do a telephone advice for her if she's worried to come in the hospital, so that we can assure her not to panic. That's most important thing. With COVID, what has been observed is that patients and women can just panic. And as you rightly said, all those worries would come. I don't want to come in the hospital. What would happen to my pregnancy or to the baby? So that's important that we provide her that reassurance and also provide the necessary support, be it patient support group or counseling support. As regards management in this case, what I would say is that I would get the history, detailed history on the phone. And if I'm concerned that pain on the left side, or if she's got any risk factor for ectopic pregnancy, is concerning enough for me, even with light bleeding, I may offer her face-to-face appointment in the hospital despite the COVID situation, and whether I see her in a COVID area or in a non-COVID but with appropriate PPE would depend on her COVID risk status. However, if the pain is more like light cramp or something, then I may recommend to her, watch your symptoms, but contact us 24 hours free advice, a free contact number, so that she can directly with open access contact us and assess her. So that advice may change based on how her symptoms proceed.
Thank you very much, Dr. Choudhary. We are slowly approaching the end of the coffee break, and I am pleased with the topics we managed to cover in such a short time. Just to summarize, we are still in the early stages of coronavirus episode, and we do not have a lot of knowledge related to the effect of COVID-19 on early pregnancy. Data reported so far are quite reassuring in the way that COVID-19 does not seem to affect pregnant women more than other infections. The delivery of care in early pregnancy has been affected by COVID-19, and the focus is on safety. If patients have any concerns or are unsure of what they should do in relation to their symptoms of early pregnancy, they should ideally contact their midwife or the local early pregnancy assessment units for advice. I hope you will enjoy the rest of the afternoon, and we'll see you next time. Thank you for attending. Goodbye.